session. So we heard about management of gastrointestinal symptoms in the last session, and today we'll be hearing about two symptoms. One is respiratory symptoms and the management in palliative care, and we'll be talking about a very important topic which is very commonly seen also, which is delirium. So for the first session on respiratory symptoms, we have Dr. Rajam. Dr. Rajam is a pulmonologist and a palliative care consultant in Bhatia and Hinduja hospitals in Mumbai. She has done her palliative care training from TIPS and as well as from Cardiff University. And she has integrated palliative care in her daily day-to-day pulmonology practice very well. And she is a faculty with us for many years now. And glad to say that she's also a trustee of Pallium India. Then we have another faculty for the second session, which is Dr. Ritula. Dr. Ritula has done her MD in palliative medicine from Tata Memorial Hospital in Mumbai. Currently, she is working in emergency department in Pune, and she is integrating palliative care practices in her setting right now. She's also with us for quite some years now. So sorry for that glitch from our side, but I think I have introduced Ritula and welcome both of you, Rajam and Ritula. And first it will be Rajam's session, and then we'll come to Ritula. Thank you so much for joining us, both of you.
Thank you very much, Sridevi, and thank you, Pallium, for this opportunity. So, from what I understand, Sridevi, this bunch of people have just recently joined and they've finished 6 sessions of training. Is that right?
Yes. And all of them are from various medical colleges in the country, and this is a part of undergraduate palliative care integration in the undergraduate MBBS program. So they have gone through initial few sessions on pain and
part of teaching hospitals.
Yes, all of them are faculty from medical colleges.
Excellent. So that will be nice. And I realize that you have 2 sessions back to back, which is quite a bit of intense information. So let's make it interactive. Otherwise, it is going to be very boring for you. Especially this is the post-lunch session of a working day in the beginning of the week. So let's make it interesting. Please do drop in questions. Sridevi will pick it up as and when. I'm happy to stop. Do not have any issues about interrupting me. It's best to sort it then and there, and both these topics can be quite something to listen to, so let's make it as interactive as possible. So to begin with, being a pulmonologist, I think I can start by saying that 7 to 8 years ago, when I actually did only pure pulmonology and then got into palliative care because of a personal loss, I think my life changed as a pulmonologist. And I really hope to bring that across to you today, even if it is a virtual session, to see how much satisfaction as a doctor one gets if you look at a patient holistically. And even if you're not able to cure or have solutions for all their problems, just by acknowledging and addressing their problem itself makes a big difference to patients and caregivers. So Sridevi did mention that you already have heard about gastrointestinal symptoms and how to have a palliative care approach. The reason I put up this slide always, though it's a little outdated and I really need to look at the current statistics, but we need to focus on palliative care irrespective of the disease or the condition of the patient. So one of the things which one has learned over the years is that palliative care is a need-based science or an art. It's not dependent on a diagnosis or a prognosis. So it's not just meant for cancer patients at end of life, which is the reason palliative care began in the modern era, somewhere in the late 60s. In Europe, it was designated specifically for patients with cancer and for patients who were actively dying or at end of life. Now, here is the time we need to emphasize, especially to our undergraduate students and the doctors who are eventually going to be looking after us, that palliative care is meant for all, because palliative care is addressed towards health-related suffering of not just the patients, but the caregivers. And therefore, we also need to emphasize one step more, which you all must have heard in the previous 6 sessions, that it is not just the physical needs of the patient, but psychological, emotional, financial, social, and spiritual. And I'm sure most of you who are now working in the medical colleges are therefore have reached an age where you have an elderly parent or a grandparent or an in-law whom you have looked after, and you know the amount of stress, tension, and the amount of juggling that we all do when we have to look after somebody who is sick at home. Why is it different for our patients? So what is the importance of putting up this slide is that today in India, a lot more than say 40 to 45% of Indians are affected by lifestyle diseases, which could be blood sugar, it could be hypertension, dyslipidemia, cardiac, stroke, and respiratory illnesses, including tuberculosis. A large part of Indians are affected by these lifestyle diseases. We cannot cure diabetes, blood pressure, dyslipidemia, ischemic heart. What do? We control these conditions. Therefore, automatically, a large amount of Indians already need hand holding for their chronic lung disease, for their chronic illnesses. And lung disease is no exception. That this slide is to emphasize the need for palliative care in all non-malignant conditions also. And it is important for us to realize that as doctors, we probably manage to cure only 1/3 of the conditions we see, which are most likely infections. The middle other 1/3 are the ones which we control, and the last 1/3 are conditions which are incurable. So in respiratory medicine, there are many of those incurable conditions. Can any of you name the incurable conditions which are related to respiratory medicine? Any of you, if you could send a type messages, and I will go on from there. So if you see that in India, the incidence of COPD, which is chronic obstructive pulmonary disease, incidence of interstitial lung disease or ILD, as well as TB, all this is on the rise. And unfortunately, it's not just the air pollution, but also domestic pollution, which results, and smoking, of course, which has led to the rise in COPD. In TB, unfortunately, despite being an infectious disease, these things, man-made, physician-made issues of drug-resistant, multi-drug resistant, extremely drug resistant, and totally drug resistance is extremely sad to see, because in India today, we still lose one young person per minute due to tuberculosis in the productive age group of 15 to 49. Patients of COPD essentially are probably more or less 60 plus. Interstitial lung disease can affect people as young as 30 also, but unfortunately, TB affects only young patients and with this horrible kinds of infections. So we are seeing more and more patients who are getting chronic lung diseases, which are probably incurable. So there are lovely responses. I love this group for almost a dozen responses, and all of you are correct. COPD. Now, asthma is probably not curable. That is correct. But sometimes children outgrow asthma at puberty. So actually, they could have had asthma in the childhood and never had asthma. And asthma being a reversible airway disease, many patients, unless poorly treated, do not end up in what we call as a chronic persistent state. So like, for example, my mother is 85 and she's an asthmatic, but thankfully she's still able to function well because her asthma has always been well treated. So yes, interstitial lung disease and especially IPF, I can see that response, which is excellent. Idiopathic pulmonary fibrosis, a form of interstitial lung disease, also called as Hammond-Rich syndrome, which is comparable to certain kinds of cancers. And if you have diagnosed IPF in certain patients, actually the lifespan of the patient is somewhere between 2.5 to 4 years, and it is incurable. Pulmonary fibrosis with a complication of ARDS. Yes, cystic fibrosis. Now, cystic fibrosis is a genetic component, and now they do offer lung transplant for these patients. But yes, it is one of the incurable post-radiation. So any kind of interstitial lung disease. Thank you for all those responses. So here you realize that these chronic respiratory illnesses result in the permanent anatomical distortion of the lung. And hence, whatever treatment we are... Shall I continue? Somebody, I think, is talking, so I'm not sure whether...
You may please continue, ma'am. It was just registered.
So these conditions result in a permanent anatomical destruction of the lung, and therefore all the treatment aimed is towards symptomatic relief. So we need to realize that these conditions being progressive, these conditions being incurable, we really need to integrate palliative care in chronic respiratory diseases. By now, all of you must have seen this graph, but today I'm going to focus only on graph C, which is typical for an organ failure. And that could be the heart, the lung, the kidney, the liver, as well as neurological. So if you see this particular graph C, and suppose you notice that this patient was probably diagnosed COPD, say at the age of 60 or 65, and his trajectory continues for about 10 to 15 years at least. So our patients with chronic respiratory disease, especially airway disease, interstitial lung disease, some slow form ones do last for 10 to 12 years. The progressive IPF ones don't last that long, but if you see, these patients lead a prolonged period of time with a high symptom burden. Secondly, non-malignant chronic conditions are not perceived as life-limiting. What do I mean by that? For example, today I diagnose a patient who have lung cancer. The next question probably in the patient's mind is, oh God, how much time do I have to live? But if you diagnose a patient to have COPD or ILD, not often or very rarely, patients, the next question will be, doctor, how long do I have to live? Because even pulmonologists do not declare and disclose the exact trajectory of the illness. And this particular patient leads a life with frequent dips that you can see and probably hospitalizations. Doctors or pulmonologists see them during this active drop. And what happens to these patients when they go home? If you see, their quality of life is clearly dipping after each hospital admission. So are these patients able to self-care? Are they able to walk on their own? Are they going to be able to look after themselves, feed themselves? How breathless are they? What is the quality of life? In India, the focus has long been culturally and traditionally on the quantity of life. Sada Ayushman Bhava. But the point we really need to bring to our patients is, are we improving the patient's quality of life? So are we adding life to their years or years to their life is the question we need to ask. And we really need to change the young minds who join medical school and reiterate to them that yes, there is probably a lot of glamour attached to becoming a doctor, but we cannot afford to forget to be compassionate, and we have to be empathetic. So at the age of 18, it's very difficult to ask them to be empathetic and compassionate, but we really need to train the young minds because they're also not experienced death, dying, sickness, chronic illness in their personal life. I can see there's a chat. Is it of significant? Not able to see the graph. uh what can it, I'll send the presentation. No, you're not able to see the graph.
We can see it.
Okay, so anyway, Jyoti, we will send you the presentation. That's not a problem. So so therefore we need to realize that since our patients suffer through this prolonged period of time, this suffering is not budgeted by anybody, neither the patient nor the caregivers nor the doctor, and it's just assumed that this patient is sick, so somebody has to keep looking after them. So please remember that it is important for us, thanks Jyoti, that we need to integrate palliative care in medicine, irrespective of the diagnosis and the prognosis. So coming again to look at it in another angle. So if you compare any chronic illness, say it could be CKD, it could be cirrhosis, it could be congestive cardiac failure, and it could be any of the chronic lung diseases, the trajectory of this patient's life is typical to falling off a skyscraper. Now, typically, till very recently, I have always ended up seeing patients when they're almost about to hit the ground. Okay, so this patient is giving us a lot of time. He's slowly deteriorating. What do we choose? We do not choose to foresee and foretell. You and me are doctors. You and me have seen 100 patients of COPD, maybe 100 patients of CKD. We know the disease trajectory. So whose onus is it to sit down with the patient and the caregivers and tell them what they are in for the future? It has to be us. For that particular patient and the family, their whole attention is to make that patient well. But it is your and my onus, with the knowledge and the training we have, to foresee and foretell. Therefore, as the patient is deteriorating, we need to punctuate it with timely, unhurried, sensitive conversations about what may be there in future and what the family and the patient should expect. So you need to also say that it is not that this will happen, but this may happen, and they need to be prepared, because it is very hard to have conversations when the patient is in a critical state in the ICU and the relatives are sitting outside. Do not have the mind space to talk and discuss about this. The manner in which you land depends on the way you fall. So if the fall is punctuated well with unhurried, timely, sensitive conversations, that is when the patient and the family are prepared that this might happen. Because you need to remember that you will agree that it is easy to learn to swim when the sea is calm and not in a storm. So before the storm hits the patient, we need to get our act together and have the difficult conversations and the difficult dialogues, which is also a skill which we need to impart to the young minds of communication. And communication, when done well, is always remembered, and a poor communication is never forgotten. So please remember, we need to teach our future doctors how to talk and when to talk, what to talk, and to whom to talk. So communication is very, very vital. So what really we want to do is integrate palliative care in such a way, even if doctors are uncomfortable to do it at the time of diagnosis, which is ideal, but at least to start at a time when the patient is declining and there are fewer treatable curative options. So by integrating palliative care with the curative care, patient also feels less abandoned. The transition from curative to palliative is much more smooth. It's not like how it happens now, saying when the patient is dying, everybody thinks of me. And suddenly the patient is saying, why am I talking to this new human being? We really need to integrate this, because palliative care can then take over when there is no curative option. And then it extends to the stage of end of life care, where the patient is actively dying, where we prepare the goals of care, where everybody is prepared what to do, where to go, admit, not admit, ICU, no ICU, ventilate, no ventilation, resuscitation, what is to be done. Everything is charted, everything is discussed, everybody knows what to anticipate, and therefore the patient and the family are better prepared. And we also follow up once the patient passes away, because it is a huge void and a permanent bereavement and grief for the caregivers, especially in a condition like dementia, COPD. In certain cases of in neurological conditions, the patient has been for a long time the main focus of the caregivers, and the sudden void can be quite devastating for the caregivers. So the other very common questions that pulmonologists ask and find it very difficult to answer is, if we refer the patient too early, it is like giving up and the patient loses hope. So therefore, it is important for me to bring up this issue of when to refer. So if ideally, you should refer as early as possible. So in certain conditions like motor neuron disease, in certain conditions, say like idiopathic pulmonary fibrosis, like pulmonary hypertension in a young adult, like congestive cardiac failure in an elderly adult, you need to actually refer at the time of diagnosis. But if that has not been done, the surprise question which has been researched in England is, when you are sitting and seeing the patient in OPD, in your mind, think whether this patient will be alive for the next 1 year. Is he going to be there for next Diwali? If the question's answer in your head is no, the probability of this patient being alive is less, that is the time for proactive palliative care. And to make it simple, there are two documents that you must read, which Pallium India will share with you. One is the Manipal's Blue Maple, and also the Gold Standard Framework, which actually gives you indicators in every chronic condition, starting with the heart, the lung, the liver, neurology, everything. So I've picked up the indicators for referrals for COPD. So if you see these points, I'm sure any pulmonologist will then find it easy to refer and integrate palliative care in their treatment. So if you have a patient with COPD, so if the age is above 75, so usually COPDs are elderly, and if he satisfies any two of this criteria, which means recurrent hospital admission, breathless at stage 4 or 5 of the Modified Medical Research Council, deteriorating lung function, on 24/7 oxygen, needing ICU admission, and extremely uncontrolled comorbid factors. So if the patient has any two of this criteria, he is probably not going to make it to the next 12 months. And that's the time to integrate, because it gives you enough time to get to know the patient and the family, to get to convince the patient and the family, to get them to process and analyze and prepare what they want from us. So finally, please remember, it has to be the decision of the patient. And for the patient to make a decision, he needs to be physically well, to be mentally competent in order to make these important decisions. So this also brings to a very interesting point as to who is deciding the patient's last journey of life. It has to be the patient, and that is one of the first pillars of medical ethics, which is autonomy. So these are the two documents I was talking about, and I request Pallium India to send it to the candidates. Unfortunately, world over, even today, non-cancer palliative gets late referrals, and in a research published from the West, even today, only less than 2% of patients with non-cancer get palliative care at end of life. Also, because palliative care is not understood as a concept, these patients of end-stage COPD, end-stage ILD, end-stage pulmonary hypertension, or advanced chronic lung diseases end up getting more unnecessary, futile medical invasive treatments like ventilator, like ECMO, like CPR. Fewer of their symptoms are documented, and therefore they have a poor quality of death. And that is also very important to focus, because it's not important only to focus on the quality of life. It's also important to focus on the quality of life till death. We need to see that in a patient who has reached the end of the road, we should not be subjecting him to unnecessary medical treatment in a resource crunch country like ours. We need to try to explain much beforehand as to the futility of these medical interventions, right? And there's an interesting study published where also they said that even if you admitted patients with acute exacerbation of COPD, hardly 25% of these patients remain well with a decent quality of life, and 50% of these patients get readmitted. And almost 65 to 75% of patients are dead in the first 3 to 5 years. Unfortunately, the research on the outcome of intensive care treatments in COPD is not generalized. So, for example, you have patients with breast cancer, 5-year survival rate. The patients with lung cancer, the survival rates. Since the trajectory of non-malignant conditions is unpredictable, it can be stormy. For example, very often patients say, my father went to ICU once, twice, and he's come back. So why can't he go the third time? The point is not that, it's also the fact that COPD is incurable, and the amount of suffering that the human being has to endure. So the whole point is we need to explain to a patient about his condition in a very sensitive manner, support him, and also help him make that decision, but not make that decision for himself. So coming to one of the important aspects of how you will evaluate a patient with chronic advanced lung diseases, all of you know about detailed history, examination, chest X-ray, ECG. Pulmonary function test and arterial blood gas is very, very important. And of course, imaging, which is very advanced these days in terms of the high resolution CT scan. You have, prone cuts, expiratory cuts. You have CT scans that can be done really fast. So please don't forget to include pulmonary function test and ABG in the evaluation of breathlessness. Then when we talk to these young minds about breathlessness, at least when we went to medical school, history taking always stopped at what makes you breathless, what makes it better, is it associated with cough, is there chest pain, is there loss of appetite, is there fever? We never ask the patient how he deals with his breathlessness. So if you imagine a patient who is breathless 24/7, every minute of his life, and he's sitting in one place, what are the issues with patients with chronic breathlessness? Imagine what we felt during COVID, locked up in the house, not allowed to go out. Even in good health, we were frustrated, angry, upset, anxious. And this patient of ours is breathless 24/7, where he's dependent on caregivers to take him to the toilet, to give him a bath, to give him feeds, all of that. So just imagine what our patients are going through, right? So obviously they're socially isolated, they're frustrated, they're angry, and probably the only thing that is working over time is their mind. So they are anxious, they're scared of death. So all this is something we need to make, learn, teach our young minds to ask. And how do we ask? Typically, when patients come of, say, advanced lung diseases, we tell them, is your breathlessness better? Or are you worse? We ask closed questions. This is another aspect in communication skills. You will learn to ask open-ended questions. And to get a better effect of what you actually want of his daily routine, you need to ask him what he has stopped doing because of his breathlessness, or what are the things he would like to do if he was not breathless. So best is, what have you given up because of a breathlessness? And that opens the Pandora's box. I'm not able to go to the toilet alone. I'm not able to go to shopping alone. I cannot play with my grandchild. I cannot talk with my friends on the phone. And those are the aspects which actually adds value to your life and quality of life. So please remember, the technique of asking history is also going to get you the right response. As it is, patients are scared of doctors. They don't want to feel stupid by asking silly questions. So they don't ask questions at all. But we need to be less intimidating. And that's why I think palliative care helps, because we are not just with a team of doctors, but it is nurses, social workers, physiotherapists, counselors, volunteers, which add to this group and make the safety net for these patients, so that they can ask any question to all this bunch of people, so that all their issues are addressed. And like I said, we might not have solutions for all their issues, but at least we heard them out. And it makes a big difference to say, yes, I see that this is causing you distress. Let's see what we can do to make you feel better. But in order to understand what they've given up, how their quality of life is really affected, you need to change the way you ask questions, right? And again, to describe and get into the mind of our patients who are suffering from advanced chronic lung diseases and who are breathless every minute of their life, is described beautifully in this breathing, thinking, functioning model. So the breathing is affected because the patient has an advanced lung disease. His work of breathing is more. He is going to have a respiratory rate anywhere between 20 to 40 or 20 to 35 at every breath per day, right? So he is going to be breathless and tachypneic. This patient, like I told you, is going to be housebound, maybe bed-bound, oxygen-bound, and therefore the only thing that is running active is his mind. So he could be either anxious, worried, withdrawn, depressed, not wanting to talk, or constantly getting, upset about his present condition. And that adds and feeds to the breathlessness. As all of you know, anxiety worsens breathlessness. Because he's breathless and because he's anxious and at a respiratory rate of say 20 plus, he is scared to move. So he doesn't move at all. He says, if I move a little bit also, my oxygen drops, or I'm so out of breath. And so he keeps sitting. And therefore, most of our patients of chronic lung diseases have deconditioning, because you don't use the muscles, you lose the muscles. So this is the vicious cycle that our patients are caught. They're breathless, so they're anxious. Because of that, they don't move. And because of that, they get more breathless, more anxious, and this whole thing continues. And this is the beauty of integrating palliative care into all specialties of medicine. Pulmonologists can stick to looking after the breathing by giving all the necessary medical treatment, and they focus on that. Psychologists can come in and ask and explore anxiety, fears, what is the patient's belief, what is he scared of, etc. So relaxation techniques, cognitive behavioral therapy, maybe even antidepressants. Then comes the physiotherapist, which is as important as pharmacotherapy in any advanced lung disease. So physiotherapists help the patient build stamina. So like you and me have to train to run a marathon, our patients of advanced lung diseases are trained to go to the toilet, are trained to take a bath. So how to conserve energy, how to pace activity, how to sit down and shower, how to, do relaxation techniques, small activities that help them ensure that they can do activities of daily living with less effort. It does not mean that they improve lung functions. No, with the existing lung functions, we help the patient do daily activities better. You and me will appreciate the fact that we also like to be as independent as we can, especially when we go to the toilet. It is a lot to do with our dignity, right? So even for patients at 80, 85, I see my mother, she will always want to lock the door, even though she's got Parkinson's, had a fall, asthma, but she still is, that is very important that she locks the door when she is in the toilet. So it's like that for all human beings. We need to encourage their activities and their independence as much as they can, as far as it is safe. So please remember, the breathing, thinking, functioning model is the vicious cycle our patients are caught. And by the multidisciplinary approach of palliative care is where we actually help to break this cycle so that the patients can do small things. Like, for example, small things like I went to the park today and played with my grandchild, or I spoke to 3 of my friends, or I had dinner with my son and daughter. It's small victories for them, and that really does make a difference to their life. So that brings us to the definition of something that is ignored and probably underdiagnosed, which is chronic breathlessness syndrome. So chronic breathlessness syndrome was coined by a Delphi method, where it describes our patients with advanced any disease. So it could be even advanced MND, it could be CCF, but patients who are chronically breathless despite maximum medical treatment for their underlying condition. And when this breathlessness affects their life psychosocially, emotionally, and spiritually, when these patients, when their quality of life is affected, that is called as chronic breathlessness syndrome. So typically, when you have patients who are breathless at rest or breathless with minimal exertion, these are the patients you really need to explore and identify as to how you can treat these patients. And what we do with patients with chronic breathlessness is obviously first target at the non-pharmacological methods. This is another interesting part of palliative care, where medicines and writing out, dishing out prescriptions is not the main code. You sit and talk to the patient of what gives him joy, what relaxes him, what is it that makes a difference, and try to incorporate the caregivers to focus on this non-pharmacological. So if you have a patient who's advanced COPD, is almost always breathless, and if he has an acute attack, you can tell the caregivers what all to do. For example, loose fitting clothes, sit next to a window, well ventilated room, positioning of the patient. Some like to sit hunched up, some like right lateral, some like propped up. So depending on what the patient is comfortable. Second thing is relaxation techniques, which the physiotherapist can learn. Certain things that the patient can also repeat to himself, like affirmations, by which the patient feels a little calm. Sometimes music, sometimes massage, sometimes pet therapy, sometimes grandchild therapy, if the grandchild is old enough and willing to do that. So these are the things you can tell. The response by most of the caregivers is dial the ambulance and take to the hospital and take to the casualty. While if you try to do all these things, maybe the patient eventually settles down. One of the things that has been suggested in literature is holding of a handheld battery operated fan. A 30 rupee handheld battery operated fan, when blown into the patient's face and nose, neurologically, there have been studies which have shown in MRI where the brain, the respiratory center actually calms down and the respiratory rate becomes less. Just the feeling of that air blowing into the face. So these are simple techniques that can prevent unnecessary hospital admissions, utilizations, footfalls in the casualty. Because if you see an 80-year-old walking into casualty so breathless, they don't even think. The next step is ICU and ventilation and all that. If we can try to do these things, we can actually prevent the hospital admissions. Okay. So non-pharmacological, extremely important. Pharmacological, we all have been taught about steroids, antibiotics, nebulizers, bronchodilators, etc. The two important things I would like to talk today about is one, oxygen, and two, morphine. Oxygen is a drug. So please do not give oxygen to all patients who are breathless. Breathless does not mean hypoxemic. All patients who are breathless are not necessarily low on oxygen. So please first check the oxygen. If the oxygen levels are below 88, that is when the patient will benefit with oxygen. So very often, if the patient is anxious, his oxygen is 97, 98 and still he's getting oxygen. Please remember that oxygen also, excess oxygen is also dangerous to the lung because it causes nascent free radical oxygen damage. And therefore, like a saying, Adigamanal Amritam Visha. In excess, even Amrit becomes Vish. So please don't advocate. And it's important to emphasize on this because we had deaths in the second wave of COVID by abuse of oxygen. People who needed it didn't get it. Young people died, and people who could afford it, who were breathless, all got oxygen, even unindicated. So even the staff nurses need to be told, any patient is breathless, first try to find out the oxygen saturation, find out the BP. So if there's no tachycardia, maybe the oxygen levels is what he's used to. But if it is below 88, these patients will benefit with oxygen. Point number 2, which is cautious. For all patients who are breathless, yanking up the oxygen can be dangerous because in COPD, yanking up oxygen will also yank up the carbon dioxide. So you made the patient oxygen fine, but he also will retain carbon dioxide because hypoxemia is a trigger to the brain to do more work of breathing and wash away the carbon dioxide. When you increase the oxygen, you remove that drive of hypoxemia and the patient actually can become unconscious because of type 2 respiratory failure. So see the history. Is the patient an asthmatic? Then it's safe to yank up. Is the patient an interstitial lung? It is safe to yank up. But if the patient has got a history of type 2 respiratory failure, please be very cautious. Those patients will improve with non-invasive ventilation and low flow oxygen because the non-invasive ventilation will make the muscles work and throw the carbon dioxide outside. Any questions, any doubt? I'm just going to have some water. So if there is any doubt, I'm happy to chat. Hold your thoughts there. Please put in the chat. Nothing? Everybody is clear about oxygen? Yeah? Okay. The second thing which is important to talk about, there's something on the chat. Sedatives and anxiolytics. So like I said, if there has been an assessment of the patient's psychological, emotional state, then yes, anxiolytics. Sedatives we normally avoid because we don't want the patient knocked off. And unless, especially when there's an acute attack, we definitely don't want the patient to be knocked out. So there is no role of sedatives in chronic breathlessness, but yes, anxiolytics if the patient is prone to anxiety and distress. So
Ma'am, how do we conclusively make out that it is because of anxiety only that the patient is?
Multiple reasons, multiple ways. You talk to the patient, you massage the patient, and automatically the respiratory rate will come down. 1.
Okay.
2, in anxiety-induced breathlessness, the saturation will not be low. Because lungs are fine. I mean, lungs are as bad as they were. Saturation will not be low. So you talk to the patient, you massage, what is happening, kya ho raha hai? Are you scared? Are you worried? You distract the patient, automatically the patient will get. Yeah.
Thank you. Thank you.
So, and the other important thing that we are never taught in medicine is morphine. And minute you say morphine, lots of people have apprehensions, anxiety, pulmonologists fall off the chair. We please remember that we are talking of not the morphine, we are talking of morphine not in the doses which we use for pain. Low dose morphine, and low I mean like 2.5 milligrams is what we start with. Nowhere near how it is managed in pain. Morphine, because it's a centrally acting narcotic, morphine actually works centrally, so it reduces the work of breathing. It improves the tidal respiration and the volume. It decreases the respiratory rate. And in these number of years and all the published article, it doesn't cause respiratory depression because we use a very, very small dose of morphine. So what we aim to do with morphine is actually it also acts as an anxiolytic. So it calms the patient, it reduces the work of breathing, it improves the depth of respiration, it decreases the respiratory rate. So for example, if your patient was going at 25 to 30 breaths per minute, it becomes 14 to 15 or 18, like how you and me breathe. That improves the quality of life of patients. And we review the dose weekly. We usually start on need basis, then 2.5, 12 hourly. Then we make it 8 hourly, then we make it 6 hourly, and very rarely we go beyond 25 to 30 milligrams. If the patient doesn't respond by the time you reach 20, you need to reassess and think that this is not working, or the patient is not having the medication, or there is something else that is causing this. It's not necessary. At least 17 we have done a little bit of a research of patients of ours on morphine, and 80% of patients feel better. 80, I mean, the quality of life improves. So patients who have originally come to the hospital in a wheelchair actually come walking from the parking lot to the clinic. So quality of life improves immensely. And that's all we can hope for in an incurable progressive illness, where patients live well, enjoy doing what they do and what they want to do till the end. So this is how we use morphine. This presentation will be given to you. But like Dr. Kapoor asked, if you feel there's an element of anxiety, we do add morphine along with the medium-acting benzodiazepine. But if the patient has, say, a panic attack, then we also add a longer-acting benzodiazepine. So we do combinations, but this requires thorough evaluation, follow-up, review, and we have to use morphine very, very responsibly and not go where the US has gone. We cannot use it unindicated. It should be done by trained people. And please remember, it's not that we give the patient only morphine. We give the rest of the pharmacological treatment also of the underlying condition. Clarify, morphine dosing schedule is not to go 4 hours. Yes, correct. So what we do is, yes, morphine half-life is 4 hours. In pain, we give by the clock, round the clock, correct? But in breathlessness, we really need to convince the patient, the caregivers, that it is working. So we start slow, go slow. We start with SOS, and then we time it according to the bath or the toilet, and then make it 12 hourly. And weekly we review so that the patient also is convinced. And please remember, morphine must be prescribed with laxatives. In a patient who is so breathless, we cannot afford him to be constipated. So he has to be given laxatives. So it definitely improves the quality of life, and there is no side effect of respiratory depression. Please remember, the intent of palliative care physicians is comfort. It is not to end life. It is to comfort, and that is very, very important. So this brings to another important fact of terminal breathlessness. Sridevi, if I'm overshooting time, please tell me. So terminal breathlessness is something that we need to be very cognizant of, because all our patients probably experience terminal breathlessness. And for the caregivers and the patient who's awake and conscious, it is extremely distressing. And you must have already heard about Dame Cicely Saunders' famous quote, that the manner in which your loved one passes away is etched in the memory of those who live on. So we need to ensure dignity, comfort, and aggressive management of symptoms at the end of life. And one of them is terminal breathlessness. So when the patient is actively dying, this is one of the things we do. And even we do give it at home through a syringe pump or a syringe driver, combination of morphine as well as midazolam to calm the patient, to make the patient less breathless, to alleviate suffering, and so that the patient transitions in peace or sleep. But this is discussed much in advance, that when such a condition happens, and if the patient doesn't want to come to ICU, doesn't want aggressive invasive treatments, the best way to treat the patient is to sedate the patient so that the patient transitions in peace. Typically, it's given for 24 to 48 hours, not more than that. And it is almost always initiated when nothing else works. So everything else is stopped, and the patient is given this through a subcutaneous method so that the patient is comfortable. And there is a GP who reviews the patient from time to time, or a palliative care home team which review the patient from time to time, and then the doses are increased or maintained at the same as far as the patient is comfortable, along with support given to the caregivers, because it's horrible to watch your loved one die. So terminal breathlessness this is how we treat the patient. So this is called palliative sedation, and the intent is comfort. Yes, the side effect is death, but it is also something that is anticipated. And Sridevi, is there time, or what is my cutoff time?
I think you can rush through this distressing respiratory symptoms. Rutila will need another 40 minutes.
Okay, fine. So give me 5 to 6 minutes.
Sure, definitely.
Have some time for discussion. So the other respiratory symptoms that can be distressing are the ones which you can see on the slide. And again, it's important. I think cough of all this is the most important one that you need to know, because when it's persistent, it can become very, very distressing. And it has a lot of complications of inability to sleep and fractures, incontinence, cough syncope. So you need to address cough. And one thing you need to remember is cough is not necessarily only from the chest. It could be upper respiratory, it could be gastric, it could be cardiac, it could be ENT, it could also be drug induced. And sometimes in school going children, we also have seen cough which is psychogenic. So history taking again becomes extremely important. Evaluation. So when a patient comes with cough, you need to ask dinner time, exercise, bedtime, how early, how late, all of that is also important. So obviously you need to ask questions relevant to the etiology of the cough and come to that. Any persistent cough, then we need to first start with non-pharmacological, like I mentioned before. So hot water, lifestyle changes, small light meals, early dinner, 3-hour gap, propped up position, then maybe an anti-reflux medication, then hot water, lozenges. These are the things you can try. And then stepwise, you first try with cough suppressants. So one of the effective cough suppressants is codeine. So you can start with codeine. Then you can escalate it to, say, sometimes even if the patient has interstitial lung disease, he's breathless and coughing, morphine does a good work, but these have to be assessed. The other conditions where the other medications that has been reported is gabapentin. Gabapentin has been reported to actually be one of the good treatments for persistent refractory cough. And because one of the side effects of gabapentin is drowsiness, given at night, the patient then sleeps well and doesn't complain of cough. So typically we start with 100 milligram and escalate it to 300 to 600 depending on the cough. But these are the things that you need to remember about first diagnosing the etiology of the cough, therefore target treatments towards those conditions. And then also if it is intractable, these are the way you can actually help the patients. Pleural effusion, again, typically recurrent filling pleural effusion is typically malignant. And when it comes to malignant recurrent pleural effusions, we really need to focus on the prognosis of the patient. So if the prognosis of the patient is good, then we put an indwelling catheter and let the pleural fluid drain so that the patient doesn't have to keep coming to the hospital. But if the prognosis of the patient is bad, we do a one-time aspiration and then you can put the patient on morphine, low dose, as described earlier, so that the patient doesn't feel breathless and you focus on the quality of life, because any malignant pleural effusion is a metastatic disease and it is stage 4. Lastly, hemoptysis. This is a bit more tricky to manage, definitely not manageable in the house, but we need to prepare these patients that this can happen. And therefore, all patients with the potential of malignancy, for example, TB sequelae, for example, a tumor sitting very close to any pulmonary artery, or something which is going to, in the head and neck tumor, which is going to erode the carotid, there is going to be blood loss, not necessarily hemoptysis. And the danger with hemoptysis is that patients die of asphyxiation or aspirating their own blood more than losing the blood. So we need to give the patient, when at the time of discharge, the probability that he will have hemoptysis. Therefore, contact numbers of hospitals which do fancy treatments available these days, like laser, like cryotherapy, like brachytherapy, like bronchial artery embolization. These are the things that can be done to stop the hemoptysis, not to cure the illness, because it can be very scary to just cough out so much of blood. So this is important. The last slide I think I have is about the pandemic. We need to focus this, sorry, next generation of, sorry. Next generation of doctors about God knows how many more pandemics we are going to see. And if we train all our young doctors in palliative care, a lot is taken care of. For example, starting with the information of selection of patients, who goes to ICU, who doesn't, who benefits, who doesn't. So triaging and patient selection. Then about withdrawing and withholding. It's a big part of respiratory medicine, where we select those patients who are not going to benefit out of intensive care. We actually withhold care and keep them comfortable. or those people who have received invasive treatment, aggressive treatment, not doing well, time-tested trial, we start withdrawing care, removing them from the ventilator, all of all of which is ethically, medically, and legally allowed. Please do read the judgment of the 2023 Supreme Court, which also I'll request Palem India to send you across. So withdrawal, withholding, the knowledge of medical ethics, the knowledge of doing what is in the best interest of the patient. All this is important as a part of our medical training. And the other big part which we experienced in COVID was of grief, loss, bereavement, and how to cope, not just with patients and caregivers, and even amongst ourselves. We all doctors went through so much trauma during COVID. So it's important to have the principles of palliative care to all generations of doctors so that we become much more sensitive to our patients' needs, to the caregivers' needs, and become compassionate doctors so that overall we are able to improve the care experience and the disease experience of the patient and caregivers, and probably try and restore trust and faith in the profession that we are all in, which I think is at all-time low, unfortunately. Very often now, there's so much of violence against doctors. People trust us very less. And by able to communicate, gather the faith and trust back from our patients and caregivers is probably the hope for the future. And by training young doctors in palliative care, we hope that we get palliative care when we need it. So with that, I will hand it over back to Pallium. And if there are any questions, I'm happy to take. And thank you, Rutula, for being patient. Please comment a little more on how to manage a hypothetical patient with hemoptysis. So it all depends on the volume of hemoptysis, the condition of the patient with hemoptysis. So if it's like a malignant condition and the patient is not going, is poor prognosis, we still need to stop the bleeding. So what we have done in the past is given the patient tranexamic acid, or you do a flexible fiber optic bronchoscopy through a rigid and induced tranexamic acid or adrenaline in the, when you see the bleeding part, that can be done. Now, of course, there are much more things you can do endobronchially, which is like brachy, laser. We do bronchial artery embolization by the radiologist. So these things can be done. Yeah. So cold saline wash, more, I think adrenaline really does work well. So bronchoscopy is something we used to do, but it is quite scary to do these things because the patient can aspirate while doing the procedure, and it's dangerous to sedate, the chance of aspiration are even more. So in a palliative care approach of hemoptysis, the first thing is reassurance. We always say that we need to have dark towels around and not white, because white can look even more scary. So red, dark green, etc. It will look wet, but it will not look red and scary. Reassurance, preparing the patients, giving the patients information beforehand that if this happens at 2 a.m., you know which hospital to contact. So it's, those things need to be done, because we are not talking of a patient who will be cured of this illness. Hemoptysis is a side effect of his underlying condition. So TB sequelae, we have young patients who die of hemoptysis in TB sequelae because large amounts of lung are fibrous, Rasmussen's aneurysms, which just rupture from the bronchial artery. And remember, the pressure at which the bronchial artery ruptures is at the systemic blood pressure, which is 120 by 80, which can be quite a stormy session of hemoptysis. So that's the reason we need to prepare these patients. So if patients, best to tell these patients, small amounts of hemoptysis, take yourself to the doctor and get it arrested at that time. Don't wait for a big one to happen. So preparing these patients who might be potentially having a lot of hemoptysis. When is DNR appropriate? Good question. Ideally, if you have a patient who is advanced any chronic lung disease and who is stable at the moment, and the patient is able to engage with you in a conversation, talk to him then. Please talk to the patients directly. It is the patient's life, it is the patient's body, it has to be the patient's decision. And for that, you need to have a rapport with the patient. You cannot say, hello, my name is Dr. Rajam, should we resuscitate you? It's not going to work. You have to have known the patient, you have to have built a rapport, the patient needs to know his condition, because everybody loves holding on to dear life. But having said that, it is an extremely, crude and if you have done CPR, which I'm sure you have done, and witnessed CPR, is a horrible thing to do for a patient. Especially if you're going to return him to poor quality life. If you're going to resuscitate him and bring back to original quality of life, good quality of life. So, for example, sudden cardiac arrest at a public place, young man, 40-year-old, those things are different. But a patient is 80, COPD, 5 admissions, hardly any lung function, not walking, on oxygen. Why do you even resuscitate the patient to bring him back? So, have these discussions with the patient. So, any time is appropriate. For example, that's when advanced medical directive comes in place. So somebody like me has already made it very clear that I don't want resuscitation if I have irreversible chronic illnesses. I don't even attempt to resuscitate. So it is appropriate at any time which you think the patient is able to understand and process and analyze, and takes his time to decide. Rasmussen. Yeah, so no, I'm saying Rasmussen's aneurysm is a kind of aneurysm that is formed in post-TB sequelae. That is from the pulmonary artery. But I'm saying if there is a bronchial artery bleed, that bleeds at blood pressure, at systemic blood pressure. So you're correct, Rajiv, and thank you for the comment. It's important. I'm not saying that all Rasmussen's. I was just commenting that there is also Rasmussen's aneurysm in TB sequelae. So when you see them, you need to realize that you need to warn patients and caregivers about the possibility of hemoptysis, and they need to be armed with information. Any other questions, thoughts, comments, feedback, anything? So one is the Blue Maple, the gold standard framework. And do you have the article on the latest Supreme Court judgment that you can circulate, or should I send it to you? Shri Priya?
We have it, ma'am. We already have, so we will share
Give
it.
it to them, because they need, we need to stimulate this debate in the young minds also.
Sure.
Anything else? Thank you all.
I think a good way to go about it is have a advanced directive signed in. Just
How many of us know what is advanced directive, and how many of us do it, and how many of us, for example, all of us have elders at home. I don't think we've even had the conversation of having advanced directive. We
My
wait
mom-
for emergencies to come.
so I tried to initiate this conversation with my mom, and she's like, "You're there now. We don't have to worry about it. We are not. Yeah, I'm not even thinking about those
So
stuff."
you have to tell them, which I tell my mother, I'm not your doctor, I'm your daughter. You tell me what I'm supposed to do. I was not born your doctor. I was born your daughter, and that is what I will be. And it is important for us medicos to realize never to treat your own. You're very confused. And the statistics of relatives and parents of doctors dying a horrible death is very high, because we never let go. We keep holding on. Ye bhi karo. I have this person is a friend, that person is a friend, I can do this, I can do that. So please, best to dissociate. Do not be doctors of your parents. Be only the children. I've had the conversation with my mother, and the line is, if there is nothing reversible, don't take me to the hospital. If it is reversible, UTI, pneumonia, extra, then it's fine. But if it's irreversible, just keep me comfortable at home.
Nice. I may have to do it a couple more times before she comes to the.
We have to try. The whole point is, it is an aspect of medicine where we don't even try. Like yesterday, I spoke to this young fellow whose mother has apparently viral encephalitis. The neurologist has said your mother will never wake up. From March 2023, he and his wife are going completely nuts about looking after. And he was worried about some pemphigoid bullae on her right leg. I said, how is it affecting her? It is affecting you. And there are such larger issues. You're continuing to feed her. She's not even opening her eyes or moving, but she's breathing. And you're prolonging her poor quality life. The concept of, this whole dignity, comfort, quality of life is what we need to put in doctors. Because in any urban metro in India, you can do everything. But is that everything logical and in the best interest of our patients? That is the debate we need to start. So over to you, Rutula. Thank you for sitting patiently. You didn't have to listen to, you didn't need to have listened to any of this.
No, but it was an amazing lecture. It's always a pleasure to, listen to you just teach. So
So
it was
thank you all. Lovely meeting you. And good luck. I really would love to come to one of the medical colleges and see the young bunch of 18 to 20-year-olds again. So thank you so much. Thank you.
Thank you, ma'am. So without much delay, it's over to you, Dr. Rudula, for enlightening us on delirium.
I'll just share my screen with you. Can you see my screen?
You just have to put in slideshow mode. Screen is visible.
Okay, just a minute. Give me a minute. Is it visible now?
Yes.
Okay, great. So coming to delirium, quickly, what we'll cover today is the definition, what are the risk factors, assessment and assessment tools, and its management, and in briefly about what terminal delirium is. So all of us know what delirium is. It's basically a disturbance in the consciousness with either its reduced ability to focus or sustain that focus, and there is a shift in the attention. Along with this, there is a change in cognition, which can be a perceptual disturbance, which may or may not be related to a pre-existing condition or a potentially evolving dementia. This develops over a short period of time, and it tends to fluctuate not only during the day, but over the course of its period as well. And you have certain history or physical examination which indicate that there is such disturbances. So in short, it is a acute confusional state, and it's a syndrome which is characterized by disturbed consciousness, cognitive function, perception, with an acute onset and fluctuating course. Okay, so these are the points that need to be noted. It's like an acute onset, fluctuating course with disturbed consciousness, right? So what are the various pathophysiology involved? Can you just give me 1 minute? I'll just shut the door and I'll come. It's a bit of disturbance over there. Sorry. So coming to the pathophysiology, so basically there is disturbance in all the neurotransmitters involved in brain, basically. So all of them potentially can cause delirium, and it does not have to be like a decreased level of one or increased level of one, nothing like that. Any of them can cause delirium. So it can be cholinergic activation or inhibition, dopamine activation, or either reduced or increased GABA activity. There can be melatonin deficiency, especially, so we'll come to the risk factors, but lack of sleep can sometimes potentially be lead to delirious episodes. Then serotonin activity or deficiency, cortisol excess, all of these can cause delirium. Another important thing to notice here is the cytokine excess, which means that any inflammatory process can also potentially lead to a delirious episode. So what are the risk factors? I mean, you saw it there, but can someone just enumerate what can be the potential risk factors for developing delirium or any delirious episode? Let us switch on the chat. Yeah, anything that you know would be a potential advancing age, infections, okay, correct. Anything else? Like if you look at the pathophysiology, what can be the potential reasons for a delirium? Surgery, okay. Steroid use, yes. We'll come to that when and how, but yes. Electrolyte imbalance, correct, absolutely. Anything else? Drugs, various drugs maybe, because there is dopamine excess, cholinergic excess and all that. So any drug which leads to excess of these may cause, cerebrovascular, prolonged ICU stay. Yes, it's another important reason. So ICU delirium, as they call it. Okay, any neuronal disease, Parkinsonism. Okay. Anything else? Alcohol. Okay. Hepatic failure. Okay. Toxins. Absolutely. Anything else? Okay, I think we've covered renal failure. Excellent. So I think we've covered almost all of them and few more. So basically, old age. Constipation is one of the leading causes of delirium, especially in old people. So if the old elderly person has been constipated for, let's say, 3 to 4 days, then he might be at a more higher risk of developing delirium. So constipation is one of the major causes. Drugs, as we all saw, pain, yeah, very good. So infections, dyselectrolemias, any brain lesions or brain metastasis, stroke, encephalopathies, toxins, nutritional wise. So hypoglycemia may also sometimes present with delirium, pain, post-surgery or ICU stay, and prolonged immobility. That is another major reason for developing delirium. So coming to the types of delirium, usually it is divided into hypoactive, hyperactive, or mixed type. What we generally see or what we generally diagnose as delirium is usually the hyperactive type, where there is heightened arousal. The patient is very restless, agitated, and aggressive. So it needs our complete attention, right? If the person or the patient has come to you with restlessness, agitation, and is very aggressive, you will notice it very fast and you will want to diagnose what the cause is and treat it as soon as you can. Most of the time, the hypoactive ones are generally neglected because the person is quiet, he's always sleeping. There is, as such, no trouble from him, especially the elderly. So you feel that, okay, that's his usual routine and nothing has to be done. But sometimes it might be the hypoactive type of delirium, which might be quite distressing for the patient, but if he or she is unable to express that. Or a mixed type, like there is waxing and waning of symptoms. So sometimes the patient is very aggressive and agitated, sometimes is very quiet and drowsy. So statistically speaking, hypoactive delirium is far more common than the hyperactive one, but the undertreated ones are generally the hypoactive type of delirium. So there was a study which was done in elderly population where they recruited around 850 patients, where they tried various measures to in prevention of delirium. So what they tried was orientation techniques, where they made sure that there was a similar staff who were, or a regular staff looking after that certain patient. The daily schedule was fixed and they were oriented 1 to 3 times per day. They had adequate amount of activity that they did, not only physical but also cognitive stimulation. Then they had a good regime of sleep. So daytime sleep was kind of maintained to maybe half an hour to 1 hour, and they were encouraged to sleep well at night, and they were provided with all the sensory aids, so hearing aids or spectacles if needed, they were provided, and nutrition and hydration was maintained. So what they saw in this population was that there was reduced chances of delirium. There were fewer episodes compared to the placebo or to the control group. There was also the duration of delirium was also reduced in these patients, and there was a reduction in the next episode of delirium as well. So in effect, prevention, as we all say, the prevention is always better than cure. So in delirium, it's actually true. Prevention with various modalities like reorientation or maintaining their mobility with sensory aids help a lot in these patients. So make sure that they are provided in all the elderly population that come to the OPD. Coming to the assessment, so the screening would be your mini mental state examination, which is generally when we do our neurological examination. Diagnostic would be CAM, that is confusion assessment method, delirium rating scale, or memorial delirium assessment scale. The commonest one that is used is the CAM tool, which has been modified for various scenarios as well. So CAM ICU is also there, for example. So this is one of the most commonly and easy to use. So basically all of these need to be there. A and B has to be there. C or D can be present. So it should be acute in onset. It should not be like a very slow progression of the symptoms. It should be acute. And the course should be fluctuating throughout the day also and over the period of days also. Like the frequency of the symptoms can increase over the period of time, but it should be fluctuating in nature. There should be inattention in the patient. They have to have difficulty focusing their attention, or are either very easily distracted, or they keep going off track, that you're talking about something and they'll go on a very tangential topic in between. Then either of these can be there. There is disorganized thinking, which is most of the time incoherent. So it can be irrelevant speech, it can be hallucinations or illogical flow of ideas or unclear flow of ideas. Then there is altered level of consciousness. So that can either be like is normally alert, it can be hyper alert, it can be drowsy or lethargic. This is a very easy to use and commonly used assessment tool for delirium. And coming on to management, it's generally divided into knowing what is the cause of delirium. So generally, if it's a reversible cause, then treat the reversibles. For example, if it's because of constipation, then treating the constipation would make the recovery better or faster. If it's because of any electrolyte abnormality, then treating the dyselectrolemia would help in managing or treating the delirium better. Then physical safety is important, because if the patient is hyperactive and aggressive, then it's necessary to make sure that he is in a safe environment. Then the environment also should be a proper one, in the sense that the non-pharmacological measures, as we say, for delirium would be like a private room, if possible, quiet room, well lit during the day and dark during the night. So avoid artificial lights during the day, because it kind of confuses the patient, even at night. So bright artificial lights in the evening or at night time will also increase the confusion or the confusional state of the patient. So make sure it's dim or dark during the evening and nighttime, and bright with natural lights during the day. Then the healthcare providers looking after the patient should remain stable or should remain the same. Changing them frequently would lead to increased confusion in the patient. So make sure that the staff who is looking after them is a constant, or if I mean, I understand there are shifts in the hospital, so it can be 2 nurses who are looking after the patient while he's admitted, with avoiding frequent changes of nursing staff looking after them. Then the disturbances during the day and especially during the night should be minimal. So avoid taking blood pressure every 2 hourly or 4 hourly. You can make it 6 hourly or 8 hourly, once before going off to sleep and once after getting up in the morning. So avoid frequent disturbances, especially during the night. And there are some reorientation techniques that will come across further, and we'll address those. Then, as I said, potential reversibility and what are the further goals of care. That also should be taken into account while managing the patient. Then, initial management would be assessing, and if the patient is very aggressive or hyperactive, you might need to give a sedative or an antipsychotic if needed to the patient. Then you identify the potential cause of delirium and manage if it's irreversible. And of course, communication is important, and also reorientation of the patient is important. So coming to the management part, like the goals of care, if it is reversible, then what are the causes and if that can be reversed? So those irreversible causes would be actively dying patient. If the goals of care are such that they do not want to go for further management, or if they have a end of life care policy or an advance directive written down which states that they do not want to go for any further treatment, then that should be respected. Then treatment of the cause is unsuccessful. If it was a potentially reversible cause that you found out, but it is not getting reversed despite your management, then maybe it will come under irreversible delirium and have to be managed accordingly. Then treat the causes. So basically, whatever are the reversible potential causes should be treated accordingly. Then it should also be remembered that while managing the patient, the risk and benefits should be balanced equally. The benefits should outweigh the risks and the burdens of the treatment. So all these points need to be taken into account. It's always good to give a time limited trial instead of extending the management prolongedly or unnecessarily. Then outcome measures should be defined, like what are the outcomes you want from the patient, or from the family's perspective, what are the outcomes they are expecting. Those also should be explored, and they should be addressed accordingly if they are not in sync with what you know to be the final outcome of the treatment that you're going to give. Then non-pharmacological measures, these are far more beneficial than, or rather equally beneficial as the pharmacological measures. So a study by Dr. Agar has clearly stated that non-pharmacological measures are equivalent to use of antipsychotics in managing a patient with delirium. So all these like sensory aids, your sleep hygiene, your orientation measures, natural daylight and dim light during the day and night time, family members or companions to be constant, and familiar objects or pictures in the room or in the vicinity of the patients go a long way in helping reduce the time duration of the delirious episode, and also help them get reoriented back to their previous self much faster and for much better, and also help in reducing the risk for subsequent delirious episodes. So sleep hygiene is basically more of reducing the daytime sleep and maintaining a good hours of sleep during the night. Orientation measures are your basically whichever room the patient is being admitted to. So there should be a big clock on the wall in front of him where he can see the numbers on the clock and can read the time. So there should be normal numbers, not the Roman numbers, because that can be confusing sometimes. And a big calendar with clear dates and days so that they know, and the month also written clearly so they know what day it is and what month it's going on. So it helps in reorientation. Those are the measures. Family members also should come in, but again, so as not to confuse him or her more. There should be a particular set of family members who are able to look after him throughout the time of his admission. So those should be constant. And familiar objects or pictures, so photographs of family members or familiar objects that he was very fond of during his normal period should be kept within reach so that it can help him get reoriented. patient was in altered sensorium, verbally abused a caretaker nurse. On being questioned, he flatly refused. What appropriate management in such a case? Can we come back to the questions afterwards? Like I'll just finish off the thing and then we'll open it up for discussion afterwards. Yeah, I'll remember this question, sir. Thank you. They should also have a daily routine, which is fixed. So the waking up time, sleeping time should be sort of fixed, not rigidly fixed, but kind of fixed to a certain time range. Then they should be physically active if possible. If not, then they should be mobilized using a wheelchair, or even the Fowler bed is fine. There should be some sort of cognitive exercises if that's possible, given the scenario in the patient. Any leisure activities like reading or any relaxation technique should be maintained. Kind of limit the immobilizing interventions in the patient. So, catheters in both the hands, or Foley's catheter, though they can be mobilized using the same, sometimes it hampers their mobility because they are scared that it might just come off and they'll have to be pricked again and all that. So limit it to one if possible. Aromatherapy is said to be useful, but it again depends on the patient if they are actually comfortable with it or not. So those should be used accordingly. Then, as I said, the study by Dr. Agar said that technically your reorientation measures are equally, if not more, useful than the pharmacological measures. FDA has no approved medications, but antipsychotics are used. So antipsychotics here would basically be to reduce the agitation or the hyperarousal state of the patient. Then the disorganized thinking and hallucination, or if there are, then the sleep disturbance should be managed accordingly. So basically, you will give treatment accordingly. So antipsychotics or alpha agonists to manage with the symptoms, or if it's a sleep disturbance thing, then melatonin can be given to aid better sleep. So basically what you want is your anxiolytic sedative property in an antipsychotic and anti-agitation property. So haloperidol is a wonderful agent given in agitation. It does not have that much of a sedative property, but it sometimes will help with that as well. Olanzapine have both agitation and anxiolytic and sedative property, quetiapine as well. So these are the commonly used ones, at least in the setup where I've worked so far. So these will be the most commonest medicines used. Risperidone won't be a first line for managing delirious episode. For first line would either be haloperidol or olanzapine, or quetiapine can be whichever is easily available. Benzodiazepines are not to be used in a reversible delirium because it has amnesic properties. So these drugs, they will increase the confusional state in the patient. So these should be avoided if possible, but they are sometimes used to manage the aggressiveness of the patient, just to sedate them a bit more faster than, let's say, your antipsychotics, because they are generally available in oral formulation. Haloperidol is available in injectable, but not the other ones, not easily. So usually midazolam or lorazepam may be given just to manage the very agitated, aggressive patient, but generally they should be avoided if the cause is potentially reversible. Then again, so it's important to know that we should give antipsychotics as the first line, avoid benzodiazepines if possible, but it is necessary in your withdrawal of alcohol or sedatives. So it should be differentiated when to use and when not to use. Then again, the agitation that the patient suffers through should be treated as a breakthrough symptom. So whenever there is an episode of agitation, you can give the PRN doses or the SOS dose of haloperidol. Usually haloperidol comes in a dispersible formulation as well. So you can just put it, you can give it sublingually basically. So it can be used as a breakthrough symptom. Then generally for delirium, the dose starts from 2 milligrams, can go up to 10 milligrams. The risk factors, the risk of giving haloperidol would be your QTC prolongation and Parkinsonism. At low doses, it's generally not there, but if there are any other potential risk factors for the use of haloperidol, then it should be monitored carefully, or you may want to shift to some other medications if necessary. Then basically you have your D2 action with haloperidol, which is necessary here. Sedation, as I said, it's not that much. So sedation is the maximum with your chlorpromazine and olanzapine. So those would be what you would use, or quetiapine as well. So what generally you give is either haloperidol, olanzapine, or your quetiapine. But if not available and if chlorpromazine or risperidone is available with you, that is fine as well. Then for hyperarousal or agitation, alpha agonist can be used. Clonidine has its own potential risks, so that is generally not preferred, but dexmedetomidine is given and it works wonders. It calms down the patient very easily. So if necessary, and if the patient, especially if the patient is in ICU, that dexmed can be used very well for managing the hyperarousability and agitation in these patients. Then melatonin generally is used to regularize the circadian rhythm of your cycle, of your sleep cycle, sorry. And generally you start with a dose of 3 milligrams HS. So it's generally given either 2 to 3 hours before you go off to sleep. So it has its effect after 1 hour of taking the medicine. So approximately 2 hours before sleeping, you need to take it. The side effects are minimal and it works wonders to get the sleep cycle regularized. Then again, you know, which was more effective? So basically placebo was found to be equally effective with haloperidol versus risperidone. So yeah, again, the same study. Just brush through that. Then coming to terminal delirium. So basically terminal delirium would equate to irreversible delirium, wherein the patients are dying. Your goals of care are fixed to be just comfort care and symptom management and no further treating the treatable as well, or the treatment for the potentially reversible causes failed. So here again, this is just, we'll just skip this for now. So what are the signs of actively dying? So it's basically altered level of consciousness, abnormal breathing patterns, swallowing reflex or gag reflex is either lost or impaired. There are a lot of oral tracheal secretions. Patient is delirious, loss of sphincter control. Your cardiac signs would be either tachycardia or venous pooling, cyanosis, peripheral pooling. So it can go either way. You can have increased heart rate or decreased heart rate. So either can be present. Renal failure is also very frequently present. Then what are the 2 roads to death? Basically, what they mean is that the patient is delirious, right? So we are talking in a situation where there is delirium, there is bound to be delirium, but again, it can go either way. It can go the hypoactive delirium way, which is the patient becomes sleepy, drowsy, lethargic, then semi-comatose, comatose, and then eventually dies. Or it can become the hyperactive, which is the difficult road where the patient is restless, confused, has hallucinations, is incoherent, mumbling, confused. There are sometimes seizures. There can be very agitated or myoclonic reactions. Then the patient becomes semi-comatose, comatose, and then he dies. So Usually you would prefer where the patient just has his consciousness decrease gradually and becomes comatose, because that's the peaceful way of dying, as you would imagine, rather than the hyperactive delirium one. So again, as we said, we give the supportive measures and treat the experience. So here, because it is irreversible, or because you're not actively trying to treat the treatables, benzodiazepines become your first line of drug. So midazolam or lorazepam, whichever you prefer, would be your first line of management, even in hyperactive delirium, because it's terminal or irreversible. So as I said, either lorazepam or midazolam. Antipsychotics, not so much, because it does not have that amnesic property which you want, or nor the muscle relaxant property that you would want in these patients. So lorazepam can either be your 1 to 2 milligrams orally or injectable, whichever you prefer, or as needed by the patient, and it can be given every 30 to 60 minutes, depending on which route you're giving in. Midazolam loading dose would be 0.2 milligram per kg, IV or subcut. Maintenance would be 0.075. Then if it's in hypoactive delirium, even if it's reversible or irreversible, should any drugs be given or not? That is the question that we need to ask. Now, even if it is hypoactive, where there is reduced functionality or reduced mentation, the thing is that there might be hallucinations which we are not aware of. They might be having nightmares which we are not aware of. There might be disorientation which we are not aware of. So to treat this experience, sometimes giving and low dose benzodiazepines or antipsychotics becomes necessary, just to treat those distressing hallucinations or disorientation that the patient might have. So again, it depends on if the patient is going through. So basically, treating the experience of the whole delirious episode becomes necessary in managing an hypoactive delirium. That's it about delirium from me today. Thank you so much. Coming back to the question, so as I said, there is a lot of confusion that the patient may have, and if it was something that he thought he might have hallucinated, that might also be the reason why he just verbally abused. Like sometimes they just forget what they've said during those episodes. So it might very well be that he had it was a case of delirium and he was just having those confusional episodes. So if this was being done and it was just verbal, it did not turn out to be physical in the course of time, then it's not necessary to restrain the patient medically or physically. I would prefer medically restraining the patients rather than physical. But a low dose of haloperidol, maybe 0.5 to 1 mg HS, would have worked in this case, because it does not seem that I'm not sure of what the other symptoms in this patient was, but haloperidol would have gone a long way to help with his agitation. Actively dying. Okay, so the term actively dying refers to the last few hours of last day or hours of the patient, where you slowly see a decrease in the various functions of the patient. So you actively see that the patient is going down neurologically, cardiologically, or even respiratory wise, and slowly coming down. Like you see the renal function going from let's say maybe it was already low to begin with, we're just assuming. So let's say the urine output is now reduced to maybe 50 or 60 ml throughout the day. So that is a drastic reduction. So you are seeing that the renals are no longer functioning to its, not even its half a capacity. So it's reduced drastically. Then you see let's say cardiovascular wise, if you say that there is either there is tachycardia, there is cold extremities, there is cyanosis that's kind of increasing from the tip of your fingers down to your hands, or even your tongue is now cyanosed. So that basically sees basically all your bodily functions are coming down. So that, and you know that this patient will not survive post, maybe let's say just couple of hours or maximum a day. So that is a term where it's actively dying, when you know that does not have a long time. Post-op delirium in elderly. Again, if you're for sure know that because of, then I would want to avoid benzodiazepines because it increases the occupational state. I would still go for either because it's an elderly you're saying, so I would assume it's above the age of 75, let's say, then I would go for quetiapine or maybe olanzapine, which is a bit safer than haloperidol because of the QTC prolongation. How would you screen for hallucinations? So generally, if the patient is in active delirium, then getting it reported by the relatives. So maybe you can ask for like, does he or she talk to people who are not around, or does he or she try to reach for things that are not there, or just हवे में ऐसे कुछ pinch कर रहा है, or it's trying to scratch the wall for any worms or bugs over there. So such things. So these are the common things. Or does he say that someone is calling for him when no one was there around, he's in a quiet room? So you can ask the relatives if he has experienced those sort of things. So it's good to ask the relatives about hallucinations. No, so that can be delusion as well, right? To hold a rope and ask what the patient sees, that can be delusions as well. So, and it's not, I mean, it may not be practical always. So past episodes, ask about history of past episodes. That's much better.
Any other questions which you wanted to discuss or unaddressed, or you want to ask before we wind up?
I'm sorry if it was a bit hurried, but hope I covered everything.
I think if there are no more questions, we can wind up today's session. Thank you so much, Rutula, for being with us between your duty hours. Thank you so much. Thank you so much, all the participants, for the questions and interactions from your side. Thank you.
Thank you, Dr. Rutula. Thank you everyone for joining. We do know the sessions are so congested, like very extensive, like a lot to cover in a short span of time. So please do feel free to write to us in case you are having any further queries over the WhatsApp or through email. We will be definitely happy to take those up, because our end thought is to help you all to reach palliative care everywhere. So with the promise that we'll be meeting again tomorrow with another interesting topic. This is Sri Priya, along with Dr. Rajam Iyer, Dr. Rutula, and Dr. Sridhar, signing off from the Tips Eco Hub. See you tomorrow, same time. Till then, everyone, take care. Bye-bye.
Thank you.